Morning. So today I'm going to talk about how do we, across systems of care, consider trauma in both our pediatric patients and then long-term, how it might have impacts in the adults that we serve. We're going to talk about, how do we define trauma in the literature? What are our emerging understanding of what we now call complex trauma or developmental trauma? Understanding how the impacts of trauma play out in children and adolescents. We're going to discuss trauma-informed care as a universal precaution and what that means across systems and within organizations. And then digging further, we're going to talk about the trauma-informed integrated care for complex trauma. So what might that look like? Talking about those key provider roles in addressing complex trauma that may include screening and assessment for complex trauma in your pediatric patients. And then I'll discuss what are those evidence-based treatment options that are emerging to address complex trauma, specifically in children and adolescents, but there's a lot of crossover in terms of treating adults as well with these same models. So first, let's talk about what is trauma. So I think a lot of times we hear the word trauma kind of thrown around like, oh, I was so traumatized by when I couldn't find my keys. But we actually have a way that we can define what defines a traumatic event and a traumatic experience. So trauma refers to an intense and overwhelming experiences that involve serious loss, threat, or harm to a person's physical or emotional well-being. These experiences may occur at any time in a person's life, and they may involve a single traumatic event or may be repeated over many years. Importantly, these traumatic experiences often overwhelm the person's coping resources. So one thing that's very important to remember is that as human beings, and especially children and adolescents, are geared towards resilience. That is our natural response to traumatic events, is to bounce back. Resilience has been discussed has been called the ordinary magic of childhood. So, resilience is our typical response to trauma. However, when an experience overwhelms a person's coping resources and their resiliency, that may lead to this person finding a way to cope that may work in the short run, but may cause serious harm in the long run. And we see those play out in behaviors and other strategies that may not be adaptive. So, some examples of traumatic life experiences: physical, emotional, and or sexual abuse or assault in childhood or adulthood. In childhood specifically, neglect or abandonment that includes food insufficiency, lack of money to meet basic needs, homelessness, the death of a parent, divorce or family separation, family life that includes drug addiction, alcoholism, parental incarceration, violence. A serious medical illness or disease can be considered or experienced as a traumatic event, and that includes disabling conditions, loss of functioning, or invasive and distressing procedures. Continuing our list of traumatic experiences, we often think of combat-related trauma, refugee, torture, and civil unrest, witnessing or experiencing community violence, interpersonal violence, catastrophic loss through natural disasters, terrorism. We're getting more and more research around the impacts of historical and generational trauma and connected to that race-based stress and trauma. And then, of course, what we're all dealing with right now, the collective trauma that we're experiencing right now as we live with COVID-19. Let's talk a little bit about what we're starting to learn about complex trauma or developmental trauma. Complex trauma occurs when children are exposed to multiple traumatic events or experiences, and it describes the long-term and wide-ranging effects of this exposure. Importantly, these events or experiences are severe and pervasive, such as profound abuse, neglect, or ongoing exposure to interpersonal or community violence. Typically, the experience of trauma is impersonal in nature and involves their primary caregiver. So it significantly disrupts a child's physical, emotional, and mental development, their sense of self, and importantly, their ability to form secure attachments with caregivers. So what do we know about the impacts of trauma on childhood? Well, there is clear evidence that we see changes in brain neurobiology. So we have a lot of neuroplasticity throughout our life, but none more than when we're children. And so the impact of those experiences, we know, changes the neurobiology of children. There are social and emotional cognitive impairment that can present as inattention, hyperactivity, defiance, aggression, depression, anxiety, learning difficulties, as well as difficulty developing and sustaining relationships. So as a psychologist and a mental health provider, I see all of these presenting issues in my practice, and so it's important to me that I'm always considering might complex trauma be at the, an underlying factor in these presenting issues when I'm doing a differential diagnosis. In addition to these mental health issues and neurological concerns, the adoption of health risk behaviors as coping mechanisms also go up. So you see a rise in eating disorders, smoking, substance abuse, self-harm behaviors, sexual promiscuity, and violence. In adulthood, childhood trauma exposure is associated with numerous poor outcomes, including traumatic stress. And that's where you might see the emergence of post-traumatic stress disorder, as well as chronic health problems throughout adulthood, including heart disease, obesity, substance abuse, diabetes, suicide, emphysema, and premature death. Of course, it also has impacts further on adult behavior because the ability to form healthy relationships in adulthood is highly dependent on learned social skills in childhood. So children's social skill learning is directly related to the characteristics of their environment. Disordered environments equal dysfunctional skills. So violence teaches withdrawal, anxiety, distress, overreaction, sometimes underreaction, and or aggression as coping behaviors. And extreme behaviors that we might see in childhood and adulthood are often rooted in dysregulated emotional states, and that can link back to that neurobiology that we talked about. In terms of prevalence of trauma in pediatric populations, approximately 71% of children have been exposed to violence, abuse, or other forms of trauma by the age of 17. Now, when I listed all of that exposure to trauma, keep in mind that we are oriented towards resiliency. So this 71% doesn't mean that they necessarily experience the symptoms and fallout of traumatic experiences, but it does mean that they're being exposed to it. The majority of children and adults in psychiatric treatment settings have trauma histories. A sizable percentage of people with substance abuse disorders have comorbid traumatic stress symptoms that interfere with achieving and maintaining sobriety. And then a sizable percentage of adults and children in the prison or juvenile justice system have trauma histories, not to mention that incarceration in itself is traumatic. Participation in the foster care system is traumatic. So importantly, we need to understand that victims of trauma are found across all systems of care. So what does that mean? It means that we need to presume that the patients that we serve have a history of traumatic stress and exercise universal precautions by creating systems of care that are trauma-informed. So what does that mean? So trauma-informed care is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. Trauma-informed care also emphasizes psychological and emotional safety for both patients and providers. So trauma treatment, trauma-informed care is not just about those we serve, but it is for us as well, to protect us from the impacts of serving people who experience trauma. And if we know that 71% of children have experienced a traumatic event before the age of 17, that also includes us as providers. We're included in that 71%. Importantly, it emphasizes that physical, psychological, and emotional safety, but also helps patients rebuild a sense of control and empowerment. Oftentimes, they had this reoccurring, if not sustained, experience of lack of control, over their environment, lack of safety, and encouraging them to reclaim that control through trauma-informed care is just the first step in terms of treating and stabilizing and healing our patients who have experienced trauma. So some core principles of trauma-informed care. Awareness. Awareness of where everyone, and that includes providers, staff, front desk folks, patients, families, everyone knows the role of trauma in behaviors, in mental health conditions, in kind of how we cope and move through the world. Safety is always a priority, so ensuring the physical and emotional safety of others. Trustworthiness, so maximizing trustworthiness, making tasks clear, and maintaining appropriate boundaries. You know, I think our child life specialists that often work in our hospital settings are great examples of trauma-informed care providers, because the very nature of their role is to help children and families prepare and understand what procedure they're going to be going through and kind of walk them through so that they aren't taken unaware with some medical procedure that may trigger an experience of a past traumatic event. Choice is always huge. So respect and prioritize patient choice and control. And that means also talking them through what their choices are, including what their choices might be if they decide not to engage in treatment, which sometimes occurs. Collaboration, so maximizing collaboration. Treatment planning, collaborative treatment planning is a good example of this, and sharing of power with the patient. So that importantly, you're prioritizing empowerment where you're for patients and giving them skills. You know, so a lot of solution-focused interventions really focus on that, empowering patients to identify what do they already do well in order to maximize their ability to continue those behaviors and generalize them. So why is it important that we understand trauma? So quite obviously, perhaps for all the behavioral health providers, to provide effective services, we need to understand the life situations that may be contributing to our patients' current problems. Many current problems faced by the patients and their families we serve are related to traumatic life experiences. Also importantly, people who have experienced traumatic life events are often very sensitive to situations that remind them of the people, places, or things involved in that traumatic event. So we have a number of fantastic behavioral health providers that on their name badge it says licensed clinical social worker. For some of these families and children, the word social worker for them is associated with child protective service involvement. And so they may come into that relationship already with a distrust of what is should be a very trustworthy person in their life. And so just considering that might be something to think about. So does their badge instead say, maybe say LCSW, but underneath it in larger letters, behavioral health provider, rather than saying social worker in big terms, because a lot of times they may make that association, and the behavioral health provider won't understand kind of what's happening in the room. These triggers may cause a child or their family member to relive trauma and view our practice organizations as a source of distress rather than a place of healing and wellness. And I'll just give a quick personal example of something that I've experienced. So I have, when I go through that list of traumatic experiences, I've been very lucky in my life. So as a child, I didn't experience any of those experiences. But I would say as a woman, I do experience certainly gendered violence, gender oppression, things like that do impact my experience in the world. I took my daughter in to get a flu shot a few years ago, and at the last minute, she decided that she was not having a flu shot. And it was a male nurse that was giving the flu shot, and he said to me, we're going to have to give it in her thigh because you can stabilize her better. I'm going to need you to pull down her pants, hold her down, so I can give her the flu shot. And of course, he's saying this while she's having a panic attack, essentially. And so then I'm struggling, not thinking, I don't have my behavioral health provider hat on in the moment. I have my mother hat on. I'm like, following the orders of this person who's in charge in the room to pull down her pants and hold her down while she's saying to me, "Mommy, please don't let him hurt me." Now that was pretty traumatizing for me as a parent and as a woman. And she gets the shot immediately. She's regulated. She's like, "Oh, that wasn't so bad," and I burst into tears. And by that point, another nurse had come in because they heard the screaming, and so came in for support. And that taught me a lot about how we can be knocked unaware and be unprepared for a time that we might be triggered. Where in my mind it was like, well, I haven't experienced sexual assault, and so why, I don't think that that's going to be triggering. But there are things that practice could have done to kind of set up and prepare for that situation so that it wouldn't have kind of escalated to the point that it did. But sometimes, I will say this, sometimes things are triggering and unavoidable. And so that's where that sense of empowerment comes in. So telling, if he would have come in and said, "Okay, we want you to be in a gown in case we need to put a shot in your daughter's leg. We may need you to hold her still." So that she would have heard that too. Like, your parents may need to hold you down so that we can give you the shot, and here's what's going to happen. That's an example of simple trauma-informed care principles that can be applied in that setting. So it's not like you need to totally add more time to the work that you do, but it's important that you consider it. So what does that look like in terms of integrated healthcare? So as a pediatric psychologist working with Norton Children's Medical Group, my role is to provide behavioral health care in primary care settings. And so I work closely with medical providers, nurses, MAs, front desk staff who interact with children to treat the behavioral and emotional needs of the children in that practice. Children and adolescents with mental health problems, including those associated with trauma exposure, are more likely to be seen in medical settings, particularly primary care, than in specialty mental health clinics. That's one of the reasons why I joined Norton, was that I felt like I was too far downstream in traditional mental health settings, where I wanted to really, as a preventionist, I wanted to be able to come in and really meet patients where they were at. In these medical settings, where medical events and treatments occur, children and parents may undergo experiences that that in themselves can be traumatic. So trauma-informed care minimizes the potential for medical care to become traumatic or trigger trauma reactions and prevents re-traumatization. By the way, I've not taken my daughter back to get a flu shot. I send her dad with her now. And so that's an example of, like, I work in a primary care clinic. She's over it. She's older. She's fine. But it was for me, I could no longer kind of expose myself to that. Maybe when she's a 15-year-old, I'll take her back. Medical homes, they provide a care home that addresses distress and provides emotional support for the entire family. It doesn't matter what kind of medical provider you are. That is part of inherent in your role in medical services, is providing emotional support for the entire family. Trauma-informed care encourages positive coping and provides anticipatory guidance. So I'm going to be giving you a shot. And importantly, referrals, which we're going to talk about in a little bit, that lead to trauma recovery. And it prioritizes, like I said earlier, not only patient and family well-being, but also provider and staff well-being. Let's talk about who are the key provider roles or the team when it comes to addressing complex trauma in our pediatric patients. The primary care provider is an essential role in identifying and supporting over the lifespan of a child, or over their childhood, their recovery and support as they struggle with issues related to complex trauma. In their role, they can screen for trauma exposure and related symptoms. They can serve to educate families about the effects of trauma, identifying and supporting family strengths and resilience to help mitigate the psychological and physical impacts of trauma, and then importantly, be involved in that referral or warm handoff to a trauma-focused behavioral health provider. A behavioral health provider is going to be that essential person who provides a comprehensive assessment of complex trauma, engages in differential diagnosis. A lot of times these kids come into care with symptoms that may look like ADHD, may look like an anxiety disorder, may look like psychosis. It's also possible that they have co-occurring issues. So it's very important that you have a well-trained behavioral health provider who understands the assessment process and can effectively differentiate between the causes, because as we know, if we can have effective diagnoses, that leads to better treatment outcomes. And then importantly, they also are there to provide evidence-based trauma-focused interventions, which is the first line of treatment for trauma, is behavioral health, evidence-based trauma-focused intervention, which I will talk about in a little bit. A nurse navigator or case manager that ideally works within the primary care practice, because again, we want these children to have a care home throughout their childhood. As a behavioral health provider who's worked in kind of more traditional mental health settings, the goal of my work with patients is that I don't see them all the time for 18 years. So I'm, again, further up the river. So what we do want, though, and what we do know is that they benefit from an ongoing supportive relationship from caregivers and care providers. And so having nurse navigators and care managers, case managers within those primary care offices is really important to offer that case management service to ensure the follow-through with recommended services. We know that that's a big issue when it comes to referring patients out, is them actually following through with referrals. And I think we're trying to figure out how to, address that issue in making sure that warm handoff occurs, but also having more integrated care within medical settings. And then a psychiatrist or psychiatric nurse practitioner can also be a part of treatment. Medication, consultation, and management of co-occurring disorders, after we've done that good differential to make sure we don't want to necessarily, there is medication that can help address symptomology that really impacts functioning, but what we don't want to do is have it be counterproductive to the behavioral health trauma treatment. So adjunctive medications to treat symptoms that are not adequately responding to psychotherapy. So again, psychotherapy should be the first line of treatment, and then at times you want to collaborate with a medical provider in order to help maybe treat symptoms that, especially if their functioning is disrupted to the extent that they're not sleeping, or they have just significant symptoms that impact their ability to get through the day. When we look at kind of what a pediatric psychosocial preventative health model looks like, that addresses the traumatic stress in a pediatric healthcare setting, down at the bottom, very universally and basically, the children and families in a primary care setting that we're treating, even those who've experienced trauma, are resilient. They're distressed but resilient. And so in the primary care setting, the role might be to provide general support, help the family help themselves, provide information and support around the impact of trauma, and screen for indicators of high risk. Up the ladder and more targeted interventions might provide intervention and specific services services specific to symptoms and monitor distress. And that's where someone like me, who's integrated in a primary care office, but focuses on brief solution-focused interventions, can be really helpful, is stepping in and providing that level of support to address acute distress and identify risk factors that might be present. And then there are times in which that, at the top of the pyramid, where we have persistent and or escalating distress and high risk factors, where it's really important that we connect these patients to a trained behavioral health specialist in trauma-informed care. So let's talk about basic screening and assessment of trauma, and this can happen across all service lines, but in primary care particularly. In addition to typical post-traumatic stress reactions, children with complex trauma often present in primary care and other medical settings with a number of impairments, and that includes inattention, hyperactivity, defiance and aggression, depression and anxiety, learning difficulties, difficulty developing and sustaining relationships. So if you're in a role where you're working with a child or an adolescent who has any of these presenting issues, it's absolutely imperative that you consider that trauma might be a part of that. These complicated symptom presentations often lead to multiple diagnoses and misdiagnoses, especially when trauma histories aren't recognized. Therefore, screening and later comprehensive assessment are essential to capture patients' trauma histories and their associated reactions. So PCPs can effectively identify children who've been exposed to trauma, as well as those experiencing active trauma-related symptoms. And then in terms of comprehensive assessment, psychologists and other trained behavioral health providers can provide more comprehensive assessment of children to help guide treatment. When it comes to those universal screenings, you don't really have to reinvent a wheel. Don't feel like you have to go out and find some new fancy schmancy screening protocol, although I will say we get better and better every year at developing those screening protocols so that they are brief and don't take, half of your well child check. You can even just start every visit, whether that be a sick visit or a well child visit, with a simple question of, since the last time I saw you, has anything really scary or upsetting happened to you or your family? Ongoing assessment is always important. And then there are more formal screening measures. There's the original Adverse Childhood Experiences questionnaire, which I think many people hopefully are becoming more familiar with studies around ACEs. I was considering talking about that today, but I decided that hopefully many of us have already been exposed to that research. And if you haven't, today's the day. The trauma symptom checklist for children, the safe environment for every kid parent screening questionnaire, and modified versions of the ACE questionnaire are all screening tools that you can use within primary care that have been validated for use in those settings. In terms of that, just some general guidelines for comprehensive assessments that behavioral health providers will be engaged in. Let's go back to our trauma-informed care principles. So we want to create a safe environment, establishing trust, making sure that your setting is private and not in the hallway of a practice, discussing limits to confidentiality, informing patients and participants of the purpose of the assessment. So again, you're collaborating with them, you're giving them a heads up of, here's how I'm using this information. You have to understand that in some communities, research has been used to significantly harm and oppress people. And that in itself constitutes a historical trauma. And so we need to be aware that when people are wary of giving certain information, they may be, because of their own individual history with certain information being shared led to social service involvement or other types of involvement that they did not want. Or historically, they are aware that members of their own community have had assessment used against them without their consent. I think it's really important that we're aware of that when we're using these assessment tools. And importantly, using assessment tools that have been normed on the populations in which we are serving. That's very important. Gathering information from multiple perspectives. So talking to the child. A lot of times we do not, when we're giving an assessment on a child, include their own voice. And the irony in that, I think speaks for itself. But certainly considering their perspective and their report, it doesn't matter how old they are. You can get information from 2-year-olds. You can get developmental information from children across the lifespan. Caregivers, teachers, and other relevant professionals. In terms of gathering information, I see sometimes inappropriate usage of screening tools for like depression, for example, that are normed for older adolescents that are used for young children. That's a really simple fix. We can, consider that depression, for example, looks different in a child than they do an adolescent and an adult. And so we just want to make sure that we're asking the right questions given the age and the context. Using a variety of assessment approaches. I mean, if anyone has ever taken an assessment class, that's exactly what they talk about, is you have multiple sources of data that you can cross-reference. So using a good standard clinical interview. Observation, that's data. Don't lose sight of how powerful observational data is of the child alone, and then also with the caregiver. Self-report measures and parent and other observer data measures are all part of that variety of assessment in that battery. I've included a link, rather than list all of the standardized measures, I've included a link to where you can find standardized measures that's typically used in a battery to assess for complex trauma. But then you also want to evaluate other areas essential to comprehensive assessment: daily living skills, individual strengths, family environments, cultural and community support resources. So again, we're going to be using strengths as the springboard for recovery. So if you are not advocating, empowering, and identifying families and kids with the resources that they already have in order to reinforce them, you're really doing them a treatment disservice. So you're going to work as the behavioral health provider, you work with the child's team and family to make sense of those results and develop treatment plans by reviewing the results with the professionals who might be a part of that treatment plan, reviewing the key findings with caregivers and a child, helping them to understand the connection between what you found and what you were referred for. For example, maybe they thought they were coming in to see me because they have a learning disorder. They thought they had a reading disorder. And then all of a sudden I'm talking about trauma symptoms. They really need to understand how we got to this answer so that they can make better sense of the findings. And then, of course, always asking the child and family for feedback and input to adjust that treatment plan, as well as answer any questions that they might have. You want to always assess a child over time. We should be doing ongoing assessment throughout a treatment process in order to be managing outcomes and adjusting treatment plans as necessary. But symptoms may change with time. Of course, development also impacts their symptoms, as well does exposure to new stressors. So tracking change can help us update the treatment plan and adjust where necessary. But it also gives the child and family an opportunity to disclose new information as increased trust is established. I never expect to find a full story on day one. And, of course, the pressures of diagnoses in order to get access to treatment forces me to make some sense initially, but I'm always, I'm frequently adjusting or changing diagnoses and changing treatment plans as new information comes up through our treatment. Let's talk about the evidence-based treatment of complex trauma. So importantly, there are multiple evidence-based treatment models that have been specifically created to adhere to a phase-based approach and have similar effectiveness when it comes to treating complex trauma. But they tend to have some similar characteristics, and that includes prioritization of safety and stability, heavy emphasis on relationships, interventions that balance immediate goals and addressing acute symptoms and long-term goals, focus on strengths and resiliency, consistent development of self-regulation skills in multiple domains, a mastery of traumatic memories, and prevention of and preparation for losses and crises. Some examples of models that have been specifically developed to address complex trauma in pediatric populations include attachment, self-regulation, and confidence, real-life heroes, integrative treatment of complex trauma, and trauma systems therapy. I provided some kind of a brief description of what these models look like, but for the sake of time, I'm gonna keep going because we have more to talk about. Some additional treatment options that were not specifically designed to address complex trauma, but have shown to work well when working with survivors of trauma, either single system trauma they've been developed to, or single event trauma that they've been exposed to, that they've been able to kind of cater and adjust in order to address complex trauma, include child-parent psychotherapy, dialectical behavior therapy, eye movement desensitization and reprocessing, EMDR, parent-child interaction therapy, seeking safety, which is a great model for co-occurring PTSD and substance abuse, structured psychotherapy for adolescents responding to chronic stress, which is a group intervention, trauma affect regulation, and trauma-focused CBT. Keep in mind that all of these interventions, one needs to be trained in. As a behavioral health provider who likes to think of myself as a well-educated provider, if I am asked to treat someone with trauma, it will be too presumptive of me to be like, well, yeah, I think I can swing that. All of these evidence-based models really require training in them. So make sure that when you are referring to a provider, that you verify that they do have specific training and education in trauma-focused intervention. So, for example, not every CBT clinician provides or is trained in trauma-focused CBT or DBT. So inquire with that referral source before you send patients your way. Also, and this is one of the challenges that I face in my role, integrated in primary care, where the majority of my treatment is brief, is that it takes time. And that's where a primary care provider actually holds a very essential role, because that's where the time is spent, is that they have an ongoing relationship with this child to make sure that they are remaining connected, remaining engaged in the treatment that they are seeking with a community partner. 12 to 52 plus sessions is the norm for these interventions. So it is important that you know that we're not going to be, trauma didn't happen overnight, so we can't treat it in 6 sessions. So that absolutely needs to be considered. Importantly, we have to think, we need to be viewing the work that we do through a trauma-informed lens. Just because we don't specialize in trauma treatment doesn't mean that we can't be informed and consider trauma treatment. Treating trauma at every stage of intervention requires that interventions are designed specifically to address the consequences of trauma in the child and to facilitate healing. Generally, these treatment interventions and programs recognize the following. The child needs to be respected, informed, connected, and hopeful regarding their recovery. The interrelation between trauma and symptoms of trauma. So when we see and are working with patients who have substance abuse, defiant behavior, eating disorders, depression, anxiety, that we're understanding through that lens and helping patients understand what's happening and why things might be happening. And importantly, they need to work in a collaborative way with children, family, and the child's community. Hopefully their family isn't their only source of community. So understanding that that's important to use that as a resource in addition to the other professionals in their team in a manner that's going to empower children and their families to recover. Going back to just driving home this idea that universal precautions of presuming that every person in a treatment setting has been exposed to abuse, violence, neglect, or other traumatic experiences, thus allowing and creating such environments, is not going to do any harm to those of us who have, somehow made it through our childhood without exposure to a lot of trauma. I would have benefited in the example that I gave from a trauma-informed treatment model, even though I had not been exposed to the specific traumas that we listed. Trauma-informed settings are respectful and empowering, again, for both patients and providers. So that's it. I always struggle with the last slide where I'm like, how do I succinctly say, and there we go. So, there it is. Sure. Yes. Certainly early childhood, so birth to 3, we know is just a significant time of brain development. Basically thinking about what are those crucial brain developmental periods. Also, adolescence, latency age, you can see where you see another surge in terms of brain development, particularly in the prefrontal cortex. As that prefrontal cortex is developing, if they get exposure to violence and are repeatedly then developing maladaptive coping skills during that time, they're creating pathways for adult response to those similar environments, whether that be, avoiding or fighting, that fight, flight, or freeze response, while they're trying to develop, the brain capacity in order to effectively problem solve those things. Any other questions? Thank you.